All right, and we are back for the second half of the event, and we're going to move right into Dr. Weiss's second talk now regarding the medical treatment options. Dr. Weiss, are you there?
Sir.
Perfect.
Well, I'm going to make this short and sweet because I think that Frank Proudlack and the group at Leicester have the most information on the medical treatment. So I'll be brief, Frank. All right?
Okay.
Advance, please. So there's basically a variety of medical treatments, contact lenses. I unfortunately have not found that terribly helpful in the, excuse me, in the high hyperope. Sometimes I'll leave them uncorrected. I really don't use prisms, and I'd like to present some theoretical data that we've accumulated in the laboratory. Advance my slide, please. This is the way that we characterize nystagmus is in the velocity domain because the common language in the brainstem is velocity. So our analyses are not in the position domain or in the waveform domain, but in the velocity domain. And here we use a gamma distribution to capture the distribution of the velocities. Next, advance, please, and I'll go through this quickly. And what we did here was we looked at the foveation time. What was in people that see 20/40 or better, what was the minimal foveation time? And we could get down to a minimal foveation time of 10 or 15 milliseconds, which means that these people use retinal sampling. They don't seem to integrate. They just have to sample the visual information at the level of the cone photoreceptors, and then this is transmitted further where it gets integrated and higher levels in the retina and then the cortex. Now, what impact might this have on an infant with infantile nystagmus? Next slide, please. So here we've just shown that there's this when we looked at all the factors that correlated with your acuity, one that really popped out was refractive error. And if you look at the logmar acuity, so 0.0 is 20/20 and 0.3 be 20/40, you'll see that refractive error has a very high correlation with your acuity. So the person who was nearsighted saw better than the infant who was farsighted. And if you think about that, if they capture the visual world by just sampling at the level of the cone photoreceptor advance, they might do better. They don't have enough time. If you're a myope, the visual world's in focus at 50 centimeters or 100 centimeters, depending on your refractive error. But if you're a hyperope, high hyperope, you have to accommodate. So you have to have, there's a latency to onset of accommodation, and then accommodation is very slow. So if you sample the world very quickly in fractions of epochs of 10 or 15 milliseconds, you don't have enough time to accommodate. So that explains, at least for a proportion of these patients, why they might see 20/40 rather than 20/20. So the myope is better. So my conclusion based on this data is I'm going to start treating my infantile nystagmuses with patients that have hyperopia, and I'm not going to treat those with myopia. And that's really the only thing I have to add here. And I think Frank by far has the most experience with gabapentin in medical treatment and contact lenses. Okay. All right. Thanks.
Okay.
Thanks, Avery.